Thank you. Now we can open up for questions. Sorry for all the people I cut off before.
Are you bringing back the other panelists?
I think the FDA has gone.
The FDA is left. But
Yeah, the FDA is gone, so I can't ask that question. But I did want to, this is a bit of a goodwill festival here, and yet I'm hearing that we're only pooling placebo data, and in CAMD, that Alzheimer's trials were not, active arms were not contributed. So, let's talk about that, since, we really do have key people here who could be influential in their companies with academic partners, with the organizations, with regulatory. So what do people on the panel think? Carolyn, I'd love to hear your thoughts. Why can't we do that? They did it with IMI. I mean, in schizophrenia and in Alzheimer's. We heard this morning they did it with cardiovascular.
Absolutely. I mean, and I think about this even. I think about this even more broadly, about where are the edges of the pre-competitive space. I mean, that's something I think we haven't talked about that today, but that really is what we need to look at, to define where it is that that all the companies can collectively gain by pooling not only data, but expertise and other resources, so that they all get something that none of them could acquire on their own. And that's something that I know is evolving, but it now, I hope, is moving into the space where people are willing to waive their IP anxiety in order to get more benefit out of money they've already spent, data they've already collected, failed trials that they're not going to go back to, where collectively we could have an enormous public and private benefit if people were willing to contribute that to a common source that was accessible by everyone.
Can I'll add to that also, is that I think one of the big issues why people don't want to share active arm data is the worry, and potentially the risk is a hypothetical risk, but it's generally, it's not only the IP risk. A lot of times it's the risk, the potential risk of uncovering safety events. We have the issue when and that's one of the big reasons that's been taking us years to actually get this initiative off the ground, is even with because we're mainly focusing on placebo data, but we're thinking of looking at control arm data and active arm data as well and pulling that. And the question is, well, what if you pull all this data and you see a trend that wasn't discovered before? Then what happens with that? So I think that's sometimes that may or may not be a real risk, but that's definitely a perceived risk, and people are worried about that.
I just wanted to follow up, so the question, if the FDA folks were still here, and I guess everyone's gone, did Eric go as well? Was, how are they going to help? And maybe we can readdress this when I think Janet's going to be here tomorrow, if I understand.
My name is Kelly McPherry, and I have a question probably for Neil, but any panelists, please speak up. I'm here on behalf of Northrop Grumman's Health IT business. And we spend a lot of time listening to vendors come to us and say, we really should be one of the solutions you bring into one of your government customers. And the test we give them is always about unstructured data. Oftentimes they're really good at one kind and not the other, and we see the clinical standards as necessary but not sufficient. We see we've invested a lot in CDISC, so we care about that. We invest in a lot of neuroimaging, a lot of genomic skill sets, but we rarely ever find somebody who can really tackle what we think is going to be the elephant in the room down the road for clinical trials, which is integrating the disparate data types. So we've talked a lot about big data types and complex data types with dispersed provenance, but we haven't talked a lot today about the really disparate data types that come from radiology images integrated with genomic data, and then the conventional EHR data and clinical data. So if you, Neil, could talk about what Oracle's doing to invest, or anybody else wants to jump in.
Well, I think I'll just make a couple of points maybe on the technology aspect of it, and other people can comment. I think, first of all, one of the reasons you haven't seen quite as much focus on that is because there's so much opportunity for improvement and all the things you already have heard for the last 8 hours, and obviously that hasn't exactly reached its end game yet. But from our perspective, we bought the leading company in analyzing unstructured data called Endeca about a year ago. In fact, that Target example that people may be familiar with the pregnancy, that's the Endeca software. Not everybody knows the end of that story, but after the father was proven a little bit, well, anyway, it's an interesting story for those who are aware of it. But at the end of the day, what Target did, instead of stopping sending pregnancy coupon for things to teenage girls, they just started including more coupons for cornflakes, oil changes, and blouses, so it didn't look so obvious they were sending the coupons. So anyway, so this is what you have to look forward to with unstructured text mining. So I think we just announced on Monday this $100 million project with the University of Pittsburgh Medical Center, and that's a $10 billion institution, so they can afford to spend money like that. Those sorts of people are focused on that, and I just think, it's still a little bit early days for a lot of other people, at least in the academic arena, because there's just so many other demands on their IT dollars or their clinical dollars. But there's a lot of exciting things happening in pharma, so if you want to address that.
Right. So the Cal has been consuming a lot of my time in the last few months, but it's certainly something that we're thinking of as well. So that's because you're right. You need a resource for the omics data. You need a resource for the traditional clinical trial data. You need a resource for the imaging data. Right now, those are all disparate. And our question is how we're still working through how the omics data, for example, is going to get in there, and then how do you work with the alliance partners as well. So I don't have I don't have an answer, but I think you're right. Those we're all working through that, and we're working with the Oracle system to work on that too now.
Josie Briggs.
Yeah. Hi, Lynn.
And Cass.
Yeah. So it's been a great afternoon. I'm Josie Briggs. I work at the NIH, do various things there. But I want to return to a topic that's come up recurrently all afternoon, which is the challenge of getting a consensus around data definitions and data standards. And as I've thought back, as I've been listening to this terrific conversation about some of my recent experiences in this arena, and I wanted to hear from some of these very knowledgeable panelists what you thought about some of the different models that we use to do that. Walter Korshitz mentioned the clinical data element process, which NINDS has been leading, which has typically involved bringing together experts in narrow disease entities and trying to get to work from their understanding of their disease to data definitions. I've been one of the co-chairs of the PROMISE initiative, and that's really been led scientifically by psychometricians who've had a kind of big view and have tried to develop definitions, and we haven't always seen those very avidly taken up by experts in the communities, the clinical trialists, because they had their own way to measure depression, and that was HAM-D, and they weren't going to use the new approaches. And certainly one thought about this is, in general, when diseases are poorly understood, like back pain, which is one we're working on right now, it's really, really hard to get consensus. But Carolyn, I know you must have a lot of thought about this, and I'd be interested in thoughts about the process of developing consensus and common data elements, whether it should come from a broader conceptual framework or up from clinical expertise. And others, I'm sure, have thoughts.
So I'm a clinician, and for me, my whole focus, even in the job I hold now, is all about patients. And I think Lynn pointed out that my whole career has been about standards at some point or other. I mean, I spent 20 years being a clinician at Mass General Hospital. And then I was concerned about developing standards around, for the College of American Pathologists, around the way we report out cancer specimens and common data elements and common definitions conditions for what we were calling a grade in a given cancer, et cetera. And I do believe that this has to come from the bottom up. This has to come from the clinicians who are dealing with the cancers, who are dealing with the patients, who are dealing with the real diseases. And it's not always easy. First of all, you're never going to succeed if you impose this on them. They have to, this is much like the process that I talked about in CPAT, this consensus-driven. It's difficult, but someone else mentioned this method, locking people in the room, and you're not going to come out until you come to consensus. It is possible for them to do that, and they do benefit from it once it has happened. And there's been this huge evolution in medicine ever since I've been in it from, well, someone called it expert based, but I think of it as the difference between evidence-based medicine and eminence-based medicine. It was really, when I first trained it was all about poetic license. And now we think about quality medicine as being standardized, and that there are really practice guidelines, and this is the way we measure quality in medicine. And I think this is also true, that this comes up from the bottom. It's evidence-based, it's clinician-driven, and someone has to enforce it. And I wanted to ask the panel what they thought of, now the NIH doesn't have the authorities from the government to enforce something. They're not a regulatory agency, but they can put it in terms and conditions of awards. As I said, they control the purse strings. But the FDA could regulate this. And I was wondering what the panel thought of some degree of standardization, evidence-based standardization, where necessary and appropriate, being regulated. Just a question.
Yeah, so I want to answer, or at least respond to Josie's question first. In the first R24, when we did schizophrenia and also CV imaging under the same award, it came from a place of having done several therapeutic area data standards efforts. And when we first started out, actually it was under one of Bob's roadmap contracts doing cardiology for ACS. We actually went first to the clinical professional societies and to groups of clinicians and practicing clinicians for definitions of those data elements. What we did under the R24 literally is run two processes head to head. We continued the cardiology process with CV imaging, because those groups in ACC and AHA and other cardiovascular professional societies were already engaged and already ready literally to jump on defining those data elements. In schizophrenia, it was a little different. I was sort of starting with schizophrenia de novo. And so we took a very centralized approach with schizophrenia, and I gathered the knowledge initially not directly from humans, but from the way humans had encoded that knowledge on case report forms. So it's not that the initial information wasn't expert-based. It was just from a different source. What we found with the schizophrenia is that doing more of the work in a central format and providing a clinical expert committee, and then later the clinical professional society working groups, draft data element list with full definitions, valid values defined, all that sort of stuff, that was straw man they could shoot at. I was amazed at how consistent the comments were from the first round for schizophrenia. Absolutely amazed. And if anybody else wants to power in on that.
I need your help. Watson's not working right now. It goes to Neil's comments. What was the name of the admiral who brought all the chip guys together back in the, what was it? Yeah, who was that? Barry, I forgot his name. But your point is very important, Neil. We are in a global environment. That's why we can do things in the United States together that we couldn't do before, because the market is immense. My concern is that, and I listened to the debates last night, I learned one thing: don't celebrate your anniversary the night before. But back to the serious. We're in a competitive environment. The GPRD became the CPRD this year. John Parkinson bragged to me that he's got 13 million patients, and an extra $100 million, and his charter from the Prime Minister is to go to 100 million, 55 million patients in the UK. And they're also putting other money in other projects. And in a document which was issued in 2010, they state very clearly that the purpose is to better recruit patients to do clinical testing over there, because every one of you know that 40% of our studies here fail because of patient recruitment. Imagine what we're going to have in terms of competition with Brazil, with the Far East, India. It's all going to happen. Well, tell me that there are people around the world. So we can do a lot of things together. And this is my lawyer antitrust from the fellowship they paid for me way back when. But we can do a lot more. And Shakespeare was correct in terms of hanging the lawyers, but the lawyers have to know that they're in business in their law departments for one thing, to say yes, to figure out how to say yes. And that barrier's got to end.
Well, when you meet the legal department who thinks their job is to say yes, please call me, because I want a picture of that gentleman on my wall. By the way, I mean, I was fortunate to be with the Prime Minister when he announced this data initiative back in December. Actually, Michael, you were there too. It was at the conference, and we all had great hopes. I've spent, what month is this? I've spent 10 months. That HES database with 55 million patients, they still haven't figured out how to let the data go yet. The CPRD, which he says he has 12 million patients, is actually only 8. John Bell, the advisor of the Prime Minister for Life Sciences Research, told me that 72 hours ago, and still people haven't figured out how to get that. I mean, so, you know, I think you're right that some of the other countries have taken a proactive attitude, and particularly in the UK because of the transparency, open data initiatives, but it's still going to be tough to get that data and do useful things with it, because all the organizations that have been told to try and make that available for research have never done that before in their lives. So it's going to take a while, but I think your point is right, is that if other countries are going to take that approach, we don't want to fall behind on utilizing the data that we have in the U.S. healthcare system.
Let me make one quick remark. The day before yesterday, Rob Kolodner and other people working with Rob went live with the medical record system in Rwanda.
Okay, we have time for one last question.
Oh, I hate being the last one. Deborah Leonard from Weill Cornell Medical College, and I'm a member of the Genomics Roundtable. I was wondering, in the Genomics Roundtable, we had discussions about the very significant importance of disease characterization, which has come up a number of times in how you manage the data and aggregate so that there are common definitions. So I have a kind of two-part question. One is, when will we move to a genomics definition of disease? And around cancer, you can think about that, but around back pain, I'm not sure you can think about that. But it could give you the racial ethnic background in a better characterized way. And then we know that genetics isn't everything, so what is being done to standardize environmental exposure data, or at least have tools to capture that in a better way so you understand the full interaction that the genome and the environment have?
So I know that the Environmental Health Sciences Institute has some initiatives, and I think they were looking at how to do data sharing better and more broadly earlier this spring, and I think had a new initiative that they wanted to go forward with to do that. So I can't speak specifically to what that is. We had a program 2004, which I can mark by when my son was born, that initiated a 4-year program to look at genes and environment, and part of that, the environmental end of it, was actually to create some standards because it was so hard to do, and there needed to be some work done just to have any basis against which to compare the data. And that was a secretarial initiative, so it was money for 4 years, and that is included, and it's all available through the database for genotypes and phenotypes, and people are using it. But of course, there's more to do.
Okay, thank you, and I want to thank all of our panelists for an excellent job.